Looking at our timeline for today, we'll go ahead with introductions as we always do, and then our Zoom poll. And then we've got a case discussion or kind of a question that got sent in that we'll discuss. We'll look at our data, current numbers and cases and everything like that in Nevada. Then we'll watch the video presentation on that topic there, and then wrap up with some announcements. I do first want to apologize if anybody accidentally joined yesterday. Because of that holiday yesterday, we moved that session from yesterday to today. So I'm sorry if you signed on yesterday looking for us and we weren't there, just push things back a day, but glad to have you here now. I'm Troy Jorgensen. I'm the program manager for Project Echo Nevada. Go ahead, Dr. Levy.
Hi, Mordechai Levy. I'm a geriatrician and also medical director here at Project Echo Nevada. I think my interesting fact today is, I guess mostly just that I appreciated yesterday being MLK Day and a lot of the messages that he had spread and found it very pertinent to the way that I was hoping to keep my mindset in the months and years going forward. So happy to see everybody today. Theresa, if you would introduce yourself next, please.
Hi, everyone. I'm Theresa Watts. I am an infection control nurse at a skilled nursing facility and a professor at UNR. My fun fact about me is actually that when I was in my master's program, I really focused on climate change. And in my PhD program, I really focused on infectious diseases. And now I've been really thinking about these fields bridged together, especially in our pandemic. And after last week's session, I really went home and was thinking about the case that was discussed. And I did find some language about gown use and for mass surveillance testing among residents from the CDC. So I figured I'll just put it in the chat. So whoever created the case last week, if they want more information, they can look at this link. But the CDC does say gowns can be used for multiple patients if the person is using minimal contact. So I just wanted to kind of mention that as a way to reduce waste given the pandemic and the way we're using waste with this pandemic. And I'll put that link in the chat.
Awesome. Thanks, Theresa, for following up on that. Looking forward to seeing that resource. Dr. Pandori?
Hi, I'm Mark Pandori. I'm the director of the Nevada State Public Health Laboratory and an associate professor of pathology in laboratory medicine here at the University of Nevada, Reno. And an interesting fact about myself, I got a real doozy for everyone. It's like a big drum roll, but I'm going to tell you next week.
Well, we'll wait patiently for that one.
It's going to be good.
All righty. Steve Matlis, do we have you on with us today? Not seeing him here. So Regina, go ahead.
Hi all, I'm Regina Neal. I'm the quality improvement coach from IHI. I'm very happy to be here with you today.
Thanks, Regina. No Dr. Phillips today, so Sneha.
Hi, everybody. My name is Sneha Sharma, and I'm the program coordinator for Project Echo Nevada.
Thanks, Sneha. All right, and our newest team member, Nathan.
Hi, everyone. My name is Nathan Moltante. I'm the new program coordinator for Project Echo. I'm also a health educator here at Washington County Health District, the sexual health program. A fun fact about me, before COVID and everything kind of started, I was actually a freelance concert photographer. So I am very much looking forward to taking photos of concerts again once all of this is kind of blown over.
Thanks, Nathan. All right, so our Zoom questions for the day, Sneha will send those out for us. So first question here, have you received the COVID-19 vaccine? Yes, just the first dose. Yes, both doses. I have not yet received the vaccine, or I do not plan to receive the vaccine. So looking forward to your responses on that. And that's just our one question for the day here.
And I apologize, those typos, I apologize for those. It's not does, it's doses. So thank you.
while we're waiting for the rest of the responses to come in there. Appreciate those of you who've already sent in your information through the chat box, the Zoom chat box for us. But if you haven't done so already, please share your name, your credential or role, and your location through that Zoom chat box, just so we have that for our attendance records here today. All right, maybe just another 20 seconds here on the poll. Alrighty, I think we'll end that now. So looking at the results here, we got 44% yes, just the first dose, 32% have received both doses, 15% have not received the vaccine, and 9% are not planning to receive the vaccine. So thank you all for your responses to that. Really appreciate you responding there. So we'll get into our case review and discussion here today. So a reminder about our case review format is I'll pull up the form, we'll kind of take a look at it, look through the information and the main question on there. Then we'll have an opportunity for clarifying questions. So that's where you can jump in and maybe get a little bit more information or kind of ask for some more info. Then we'll get into recommendations and then a nice summary and wrap up from our team. So I will pull up that form here. So this one was sent in from Jennifer at Hearthstone of Northern Nevada, asking, we have had a number of staff that declined the COVID vaccine due to autoimmune diseases. They haven't disclosed which, but are generally healthy and fear triggering a response such as lupus, etc. Also, I have a handful of nurse friends that declined the vaccine because of some recent study on triggering Bell's palsy post-vaccine. These nurses have a history of Bell's palsy. My go-to answer to both groups was to reach out to their primary care provider and research the risk versus benefit. I personally feel that the benefit outweighs the risk in most cases, such as Bell's palsy. If you have any additional info, it would be greatly appreciated. So this is kind of our question for the group here today. So what other information or resources have you shared with patients or staff who've asked about Bell's palsy or autoimmune conditions with the vaccine? I want to open it up to that group right now. Any thoughts on this? Please feel free to unmute yourselves or write in through the chat box.
We can call on somebody, see if that helps out. Marisol Hernandez, has anybody asked you any of these questions down in Yerington?
I have had a few employees who have issues. Like I had one lady who's on steroids and she was, concerned about that. So luckily we do have the pharmacist that comes. We had the CVS people come and vaccinate our residents and staff. And so they were able to, answer any questions that they had. And then I do have a couple of nurses that have issues like with their white blood cell count, but they both took it. So I really haven't had any issues with staff.
Did you find when the staff talked to the pharmacist that they were more amendable or felt more comfortable taking the vaccine?
Yes, they felt more comfortable taking it.
So utilizing your interdisciplinary team with your pharmacist was effective for you, Marisol. Thank you for sharing.
Yes.
What other things have people tried?
Question here from Nicole asking, do you have a link to the study regarding Bell's palsy? I haven't seen that. Jennifer says she'll look for it. Team, any other information on the Bell's palsy side effect?
I'll share a little bit. I've been getting this question actually quite a bit too. It's everything that was described in the case study. I think a lot of us have all been getting the same questions. I do think the Bell's palsy thing was maybe something more that was hyped up on social media than actually being a real study, because I couldn't find any scientific real evidence really pointing to it. But it was something that was coming anecdotally, potentially from the social media. So what I did with my hesitant staff, and I was quite successful actually with it, I kind of went through a whole process, and I'll share with you all what I did. So let's say I had a hesitant staff because they had lupus or some disease. I would pull up, we got the Pfizer vaccine at my facility. And so I would pull up the Pfizer study. I show them the exclusion and inclusion language for the participants involved in those studies. And just to kind of show them kind of who was involved in the actual clinical trial. Then I'd actually go to PubMed and say, let's see what we can find on lupus and COVID vaccine. We didn't find anything there, of course, but I'd be doing this with the person who is hesitant. And then after that, I'd actually go to like a National Lupus Foundation to see if they had any statements on their websites for the vaccine. And so basically I was kind of walking my staff member through all these different steps to kind of show them all the information I had to offer them. And through this process, I was actually able to get a lot of people who then started to feel more comfortable, because I said, this is everything I could offer you. And if there was any contraindications, we would have come across it by now. And so I turned a lot of people who were hesitant at first into getting the vaccine through this process. And I actually used my pharmacist too. I said, just come to our vaccine clinic day, talk to the pharmacist and see what they say. And some of our people did get vaccinated then. So I think the success that I really had was just really walking and showing my staff the evidence that I had, not just saying I couldn't find anything, but really showing them what I could find.
Appreciate that. Thank you very much, Theresa. Yeah, some comments in the chat box here. One from June. What I've read in response to the Bell's palsy, the amount of cases after vaccination amounted to the same ratio of people in the general population who developed Bell's palsy. No relationship to the vaccine. They would have gotten it anyway per Pfizer. And June shared a link to the CDC there. And Lisa shares, I also had a few who changed their mind after speaking with them. Okay, cool. So, any other thoughts from the group on kind of how to broach this subject with people who are a little bit hesitant to get the vaccine? Nicole shares, today was our second clinic and we had a lot more people consent at the last minute. So Nicole, you think just because they were there, they were giving vaccine, they said, I'm going to take this opportunity?
Absolutely.
So just having them there physically and being able to say, this is your chance.
Yeah, and knowing that the next clinic is for the second dose. A lot of my staff are like, well, I'm going to wait to the third clinic, and I'm like, you can't wait to the third clinic to get your first dose. Walgreens has been coming back, and so then a lot of people decided to get vaccinated today.
Great, thanks for sharing that. Awesome. Lisa also shares, many have used those of us who received the first vaccine as a barometer towards getting the second. Cool. All right, Jennifer, any other thoughts from you?
No, I think just doing your own homework and researching it, since it's such a personal issue, there's not enough data still on, immune issues with the COVID vaccine. So hopefully after everyone gets, these rounds done, we already had our second clinic, so everyone's pretty good now. Hopefully these nurses change their mind and get the vaccine. Thank you though. Thanks for everyone's input. I appreciate it.
Yeah,
Yeah.
go ahead, Dr. B.
I'll just share a couple extra things that I don't know why the echo.
Go ahead.
Okay. These mRNA vaccines don't actually have any COVID-19 in them, and so making sure people understand, even though they may be immunosuppressed or have decreased immune function, that these vaccines cannot necessarily give them COVID-19, and that a lot of the unknowns with the lack of recommendations really has to do with how people are going to respond to the vaccine with regards to how long their immunity is going to be and how reactive they are to the mRNA vaccines. A lot of the vaccines coming out aren't going to be the mRNA type vaccines, and so there'll be different ones like the potentially adenovirus type vectors to help get the vaccine in. And so this type of RNA vaccine is new, as we all know, but at the same time seems to me to be one that as far as suffering a negative reaction due to kind of increasing lupus or kind of making your autoimmune disease worse, seems very unlikely to me, just based on how I understand this vaccine to work. And as kind of everybody mentioned, I was going to share two links. I think Julie just shared the one that I did from the CDC and their recommendations, and walking people through the evidence is super important. And then also wanted to share this other article about the incidence of Bell's palsy. So you can kind of share that. It's really a more common disease than people may realize. According to this article, 1 in 60 to 1 in 70 people get Bell's palsy sometime in their lifetime. And so that's really, higher than 1% chance, all comers. And so understanding kind of how common Bell's palsy is as well is super important to understanding the risk of Bell's palsy associated with the vaccine. So just wanted to give you this one extra article to kind of help show people how common Bell's palsy is. That may help persuade them that, if they do get Bell's palsy, it may be luck of the draw rather than the vaccine. And those would be the main things I'd share. Any other thoughts before I kind of give a quick summary to what everybody shared?
I have one more thought I'd like to add, if that's okay. So, for my staff members who decide for whatever reason they don't want to get the vaccine for a health condition that they're concerned about, one of the last things I say to them is that I need them on my team still. Because the truth is that we all, the rest of the staff need to get vaccinated to protect them. So the message they need to take forward and to the rest of their colleagues is, I'm not getting vaccinated, not because they're scared of the vaccine or to convince their other peers to not get vaccinated, but really to help support getting your other peers vaccinated and to have the message of like, please get vaccinated to support me and my health. And it's just kind of a way that I try to make sure that there's no negative messaging around the vaccine from those who are hesitant to then get other people to then also be hesitant. So I think just ending the conversation with like, okay, like go forward, make your decision that's right for you, but also please like make sure you're sharing the message of the importance of the vaccine, because the more people vaccinated, the better we can protect you.
Great point, Theresa. Thank you for sharing. What other thoughts are out there before I add a summary? All right. So when kind of approaching people that may be hesitant to get the vaccine, whether it be due to concern for side effects or concern for an underlying medical condition, it's always best to first understand why they may be hesitant to get the vaccine, so you guys can start on that level playing field, and then kind of starting to move to understanding the knowledge base that's out there, both their knowledge base and the knowledge base out there, and the evidence, and walking them through, like Theresa said, could be a really helpful tool. Along with walking them through the evidence base, also utilizing your interdisciplinary team, specifically the pharmacist, seems to be a very effective way to kind of communicate and help ease some people's concerns with regards to getting vaccinated. And then I think the other thing is just to make sure people understand what we do know about both autoimmune conditions and immunosuppression, as well as Bell's palsy in the general population and how that may interact with the mRNA COVID vaccine. And we know the mRNA COVID vaccine does not have any COVID in it, and so cannot give you COVID and make you sick from that respect. Anything that anybody would like to add or correct from those recommendations? All right. So we'll share those with you, Jennifer, in an email too, so you can have reference to those as well after the visit. And really appreciate that question that you submitted for us to talk about, because as you see, I think everybody's dealing with this. It's super important to talk about.
Yeah. Definitely, thanks, Jennifer, for sending that in. All right, we'll keep moving here then on to our data update for the day.
Yeah, so this is just the general data update that we're sharing. This is the county tracker, essentially test positivity rate. The last update we have here was 117. As you can see in most counties, there is a general downtrend in a lot of them. Specifically, it looks like Carson City, especially compared to a month ago, has gone down from 29 to 11.2%. Churchill was at 18% a month ago and is still at 19%. Clark County was 20%, still at 22%. Douglas was 28, now 18%. They're rarely Elko, 26 to 13. Esmeralda, 32 to 18. Lincoln County went from 42 to 19.9. I see here Mineral County, 11.4 to 7.3. Definitely want to point out White Pine over here from 10.4 to 3.4. And then Washoe also has a small decrease from 20 to 17.3. So overall, seems that this curve, as far as test positivity rate, difficult to say exactly where we are, but there is some general trends with potentially plateauing or going down. Though we do see some are still going up, and we'll talk about that here in a little bit more in a second. Next slide, please. This is from the facilities. This is the one we shared last week, where we had 10,423 confirmed cases and deaths, 593 in residents and patients, and 16 staff. And so if you go to the next slide, you can see since we've last talked, there have been over 1,000 more confirmed cases within our facilities, multiple more deaths with infections, and a few more staff have also passed away. And so really, still something that we're dealing with, still something that's affecting all of our lives, as we all know. And so making sure that all of us are aware of this information, not only us, but the people we work with, is super important to helping understand that this is the current situation we're all still in. Next slide, please. I was kind of looking for more information to share. I didn't find anything that was, really a whole lot to talk about that I felt like hadn't already been partially discussed or at least covered. So I have four things that wanting to see if anybody was going to bite as far as talking about, as far as vaccine hesitancy, vaccine reactions, new vaccines on the horizon, and new admissions and their vaccination, COVID-19 vaccination status. Was wondering if this was anything that somebody was currently dealing with or still had more questions about. I know we just dealt with vaccine hesitancy with our case review, with in a kind of a limited frame with regards to people concerned about their own medical conditions and the potential risk of future medical conditions, but wanted to see if anybody else had any other updates that they were hoping to discuss before I move on to an article to share.
I had a few CNAs at my facility that were hesitant about taking it. When the staff was getting their first dose, they wanted to see the reaction, kind of saying that they were the guinea pigs, and then they would decide if they wanted it or not. But that was about it.
Thanks for sharing, Marisol. Yeah, definitely sounds like people are looking to other people to be the good role models and show them kind of how, at least at this point, seems very simple and risk and minimize little risk associated with these vaccines. So great point. All right, so we're happy to keep talking about anything regarding vaccines. These were just kind of 4 categories that I was thinking about that people would be interested in, and lots of new information coming out with regards to risk of anaphylaxis, which we covered last week. Discussed, briefly mentioned the 3 new vaccines on the horizon, though we don't necessarily have more information on that this week. And then I'm real interested in hearing kind of how people are going to be treating new admissions and their COVID-19 vaccination status as they try and keep their team safe and their residents safe. So I think that's a super important topic that I think each facility may handle a little differently than others. So it'll be really important to share those thoughts to see what best practice may be. Cool. So we can go to the next slide, please, Troy. So this was an article that Theresa shared with me at the end of when we were kind of debriefing last week that the CDC had released. And so just wanting to show you all of the information that you all are submitting to the CMS and to the other facilities is being used and being published, and wanted to share some of that with you today. And so this comes from the National Healthcare Safety Network, which was asking all of the nursing home CMS facilities, so all of you all, to submit surveillance by May 25th. And essentially they've kind of published the data as far as essentially the rates of COVID-19 among residents and staff members in nursing homes. And so I wanted to share those graphs with you here on the next slide. So through May 25th and November 22nd, 2020, the top graph over here shows the confirmed cases per 1,000 resident weeks. And so essentially everybody kind of filled it, every week was asked to send in their total number of residents that were positive for COVID-19. And so essentially what they did was they indexed that to resident weeks based on the weekly gathering of data, and essentially indexed it to see kind of what the number of confirmed cases per the number of resident weeks or number of weeks that residents were in these nursing homes. And so you can see that when they started collecting in May, they may have been kind of finishing up a peak. Then there was a new peak here in July. Then it went back down, and then kind of a new peak started to happen in October, and was much higher than this peak back in July or August. You can see among staff members, it really is essentially a very similar graph where you had the same increase in July and then also the same increase in November. And so this kind of shows that the staff and residents seem to have some sort of a correlation with regards to when there seem to be more infections in the nursing homes. And so next slide, please. And so what they also mentioned was that for each health region, the trends in nursing home incidents among residents and staff were like population trends in the surrounding community. And so this is kind of below here. I took the graph from our COVID-19 dashboard. It's kind of a truncated graph because I really tried to get the dates to match up just as well as I could, because this starts at May 25th again. And you can see the graph here starts a little bit before May. So you just have to adjust the graph a little bit. But you can see we still have this kind of same peaks, this one in July and August in our community, and then the one that we're kind of currently going through starting in October in Nevada. And so you can see that community spread also essentially parallels the spread within the nursing homes. And so essentially, we can say that these two are also correlated. And so it really kind of gives some validity to kind of why we're basing community spread to how often we're testing our staff, twice a week when the percentage is above 10%. So super interesting information to share. If you go to the next slide, there were just a few limitations that they noted, or at least 4. This was aggregate data. And so you really can't look at patient level analysis of any of this stuff. Also, this was not a validated study. There was nobody making sure that all the data was correct, really relying on the nursing homes to send them all of the information. And so there may be some missing data that essentially, if it's missing, will kind of really influence the results of what they're sharing. You also can't make any kind of assumptions on the direction of transmission between residents and staff. And so I want to make sure we kind of clarify that we're not, we just see these correlations with residents getting infected, staff getting infected, and community spread. And so we know all 3 of those are kind of happening at the same time, but as far as the direction, really difficult to say how that's happening. And again, this is really just a CMS qualified nursing homes. And so really need to be careful about generalizing this to other types of facilities, such as assisted living facilities or those for the developmentally disabled, because we're not gathering information and they may have a different type of environment there. So wanted just to kind of share that study. I thought it was pretty interesting. And again, really shows that we're using the information that all of you are collecting to better inform our decisions. And so would be happy to answer any questions as best I can, or any other comments from our subject matter experts on this study would be appreciated. Is anybody surprised that all of these are correlated, or was everybody kind of expecting this? Thanks, Michelle. Michelle said she was not surprised, she was expecting. So did Mark. Thanks. Barbara mentioned not surprised, but the myths are still out there, as if people know for sure. Great. Yeah, I think it's definitely important to know kind of what the evidence is, and what are just conjecture and concerns rather than true science. All right. Well, I appreciate everybody's feedback on those questions. We won't keep the silence for too much longer, and we'll get moving on.
All right, thanks for those updates, Dr. Levy. So yeah, we'll get into our didactic here today, led by Dr. Kathleen Unroe. So learning objectives for this one are: name nursing home challenges in preventing and treating COVID-19 outbreaks, identify key aspects of preparation, review navigating an outbreak case study, and then describe common clinical courses of nursing home residents with COVID-19. So I will pull up the video here.
Hello. I would like to talk with you today about managing COVID-19 in nursing homes and share some of my own personal experience with this disease. I am Dr. Kathleen Unroe. I am an associate professor of medicine at Indiana University and a scientist at the Regan Streif Institute. I'm also a primary care provider in nursing homes. My only disclosure is that I am the CEO and founder of Probari, which is a healthcare startup founded to improve care in nursing homes through implementing the evidence-based optimistic clinical care model. The learning objectives for today include: name nursing home challenges in preventing and treating COVID-19 outbreaks, which are truly familiar to any of us working in this setting. Identify key aspects of preparation. Review navigating an outbreak with some insights from the case study of my nursing facility. And I'll also describe common clinical courses of nursing home residents with COVID-19, again, gleaned from my experience with this. So nursing home residents certainly are at high risk of both getting COVID-19, but then, if infected, needing significant treatment and support. 80% of residents with COVID-19, or even maybe more than that, will survive this infection, but about 15 to 20% with COVID-19 will die. Nationally, about 40% of deaths are among nursing home residents, and that holds up internationally. Even some countries and states have even higher proportion of deaths from people in nursing homes. So we have lots of challenges inherent to our setting of care. So certainly this is true in my facility, but most rooms have double occupancy. Often there are shared bathrooms. So in my facility, there are 2 people to a room, but then 4 people to a bathroom between rooms. Different building structures truly require unique solutions to cohorting. So You may be in an urban facility that's very up and down, and you could have a whole floor that is the COVID wing if needed. Other facilities, you might block off a wing of a building, but then also depending on how many people are infected with COVID-19, that COVID-19 unit might need to be larger or smaller, and it's important to think ahead for how you would expand or contract that unit. Obviously, PPE, both getting supplies, but also training. Our labs are generally off-site, although there's certainly more access today in terms of antigen testing on-site. But the time to receive the PCR COVID-19 results has been a consistent challenge. Access to providers, particularly providers who go building to building, has been a challenge, and the use of telehealth has certainly exploded across the country, but there are challenges inherent in telehealth as well, including the need for staff support to navigate. And nursing home residents require personal care, requiring prolonged exposures, and we cannot get around the nature of that type of care. Of course, staffing and the new roles that are needed to support residents during this pandemic have placed further stresses on staffing. Of course, this is the resident's home for the long stay residents. It's different from the hospital. Quality of life considerations must continue to be paramount, even within the pandemic. If it's possible to have private rooms, that certainly is best from an infection control standpoint, depending on the census of the building. Another consideration for cohorting is that the location of break rooms or work rooms, if in my facility, the COVID-19 wing included the hallway where the physician workroom was located, so that needed to be moved during that time. In terms of PPE, many facilities lack still, and certainly did lack in the spring, N95 masks. Hospital partners may be able to help, but certainly have been focused on their own supply issues. CNAs and LPNs have minimal training at baseline in PPE use and have lots of resident contacts, so significant support in PPE training is needed. Activity staff, office staff, therapy staff, social services may have no PPE use training, and so they need it. Visitors can be asked to bring their own mask as we open up to visitation, but it will be important to have PPE set aside for them. In terms of navigating relationships with diagnostic services such as radiology and lab, these providers are generally off-site and may serve people in multiple settings of care. And we truly need strong communication lines with them, particularly if, say, the time to receive results changes suddenly. That happened to us. We were getting our COVID-19 results within 24 to 48 hours, and then it suddenly switched to 4 to 6 days, and we had to track down the reasons why for that, and it was because pre-op testing had opened up at the health system, but we needed point people at the lab to get answers on issues such as length of time to get test results, but also other issues such as who supplies the PPE for the people coming into the facility to draw labs. If we're supplying it in particular, are they willing to comply with our approach to conservation of PPE on the COVID-19 unit? We had some issues in communication needs surrounding things like that. COVID-19 testing was certainly, in our experience, initially quite limited. The only testing that was available early in the spring was through our state Department of Health, and we would test the person with symptoms, and then if they were positive, we would also test their roommate, the people who shared the bathroom, the staff with the most contact with them. But again, it was limited versus our practices now, where we test the whole house immediately when there is an outbreak of one resident or staff member. And again, variable time to results has been a constant issue, although there is more pressure now on labs to turn results around in 48 hours. And a plan for ongoing resident and staff testing, that really has been in our hands at the facility level or mandated by the states. Recently, of course, there is now federal guidance testing frequency. Medical providers may cover multiple facilities, which creates issues related to infection control. And yes, telehealth may extend access, but requires effort on the part of staff to manage, particularly for people with cognitive impairment. And again, on the resident level, personal care requires prolonged interactions, and cognitive impairment makes it difficult for residents to comply with things like mask wearing, etc. And residents have multiple comorbidities that both make identifying symptoms specific to COVID-19 more challenging, but also managing this disease when someone is infected more challenging, and also increases their vulnerability to becoming very sick with this condition. And again, staffing, we know this well. Our typical ratio of patients or residents to nurses, of both nurses and CNAs, can be a challenge when you have multiple residents who require increased care. And while consistent assignment of nursing staff has been a best practice advocated for years, housekeeping, dietary, maintenance, and activity staff are typically shared throughout the facility. So certainly our goal, our number one goal, is to keep it out, keep this disease out, and prevent all infections. We have all doubled down on hand hygiene, and we must maintain vigilance on hand hygiene. And since mid-March, state and federal regulations have restricted visitors, only now beginning to open that up. Social distancing life within facilities was shut down, again, only now beginning to open up. And clinical staff wear medical grade face masks. In fact, all staff in anyone in the facility now wears medical grade face masks. So in terms of trying to look back and understand what has been happening these last several months, there have been some studies that have come out describing factors that are associated with outbreaks. And the number one factor, and here are just a few of those that have been reviewed, the number one factor truly is the level of spread in the local community. And despite the measures that I've described and that all of us have been putting into place, outbreaks do continue to occur. And in the setting of continued community spread, the numbers of infections in nursing home residents are going to continue. We will continue to have outbreaks in nursing homes with unchecked communities. In terms of how we treat this disease, once someone is infected in the facility, it's a lot of supportive care and active monitoring. When residents are very acutely ill, we're monitoring vital signs every 4 hours. We are doing daily labs on many of these residents. Certainly, we're providing oxygen via nasal cannula as needed. Nutrition support and treatment for dehydration were very staff intensive and universal needs for our residents with COVID-19. Lots of time at the bedside, hand feeding residents was necessary when they were sick. For dehydration, again, this is why we were monitoring labs daily on many people, pushing oral fluids, and we did a lot of IV fluids. Deprescribing, we got rid of all medicines that could be paused during the acute phase of illness. Partway through our outbreak this spring, the data on the importance of DVT prophylaxis and the role of clotting in this disease was well described, and we instituted DVT prophylaxis for all of our residents with COVID-19 infection. And certainly, while we're treating them for this known infection, we have to continue to monitor for secondary bacterial infections and getting chest x-rays and discerning whether it could be COVID-19 versus bacterial pneumonia. And we had multiple UTIs we had to treat as well during COVID-19 infection. So in terms of when to hospitalize, this is no different from our considerations anytime we have a sick resident and we are deciding when to hospitalize. So we confirm goals of care are consistent with hospitalization. And if vitals become unstable despite interventions or are starting to be, then we will transfer out. And if there's an urgent need for diagnostics and therapeutics. So in our facility, we were comfortable with an oxygen requirement of about up to 5 liters via nasal cannula. If any resident appeared to have an increasing oxygen requirement and they were not comfort care, we transferred those residents to the hospital. And here we have some tools that our team developed that are all available on this website related to, especially related to hospital transfers, but really related to multiple aspects of care for COVID-19 in nursing homes. Safe transitions have never been more critical. We must have warm handoffs, provider to provider, direct communication and conversations. Clearly, COVID-19 positivity, pending tests, or outbreaks in the building must be communicated clearly. Pulsed or any other code status related communication, goals of care communication is critical, particularly for someone in respiratory distress who may have rapidly increasing oxygen requirement. The emergency department or hospital's physicians may need to make decisions quickly about whether someone would need to be intubated in the ICU. And if this would be inconsistent with their goals of care, we must communicate that information. Family contact information also has to be very clearly communicated. In prior days, the daughter who lives in town would rush to the emergency department to be at her dad's bedside in the emergency department advocating for him. And with less ability for families to walk through the doors of the nursing home to be with their loved ones, we must make sure that good phone numbers, clear contact information is available. All patients leaving the facility should have a mask on, and certainly EMS, which is a critical link in this chain, needs to have all of this information as well. My facility is a really good facility. I've been very proud to work there as a provider. It's a bit over 100 beds, although our census had been intentionally allowed to drift down by the administrator in the early spring to give us more ability to move residents around in cohort, which turned out to be critically important for us as we had a major outbreak. 78% of our residents were infected with COVID-19. We had 14 patients die from COVID-19. Of the residents who survived, we had 12 that you could almost describe as asymptomatic. Maybe some malaise and fatigue, but truly mostly asymptomatic throughout their course. And these are typical nursing home residents with dementia or multiple other chronic conditions. And so it remains amazing to me that even with all of these comorbidities, that our residents can be asymptomatic. So we had about 12 that would fit into that category. We had 42 who had significant symptoms, and they had this up and down course where I would say to a family member, I think your mom has turned the corner. She seems to be getting better. I think we're through the worst of it. I'd say things like that. And then the next day have increasing oxygen requirements. So it was just very difficult to predict. And these residents really suffered with multiple symptoms. And these were the ones who really suffered a lot with the dehydration and the nutrition and needed a lot of support. Of our 14 residents who died, 9 had symptoms that steadily and slowly worsened over time, and 5 got sick very quickly. Rapid onset of multiple symptoms. The most common symptoms were fever, hypoxia, and then the anorexia I've been talking about, fatigue and malaise. But of course, in our population, true for any time our residents get sick, we must watch for atypical symptoms. We had delirium, increased agitation behaviors as our presenting symptom for multiple residents. Overall, our mortality rate was 20%. 8 of those residents died in our facility receiving palliative and comfort care. 6 died in the hospital, 2 of those on ventilators in the ICU, consistent with their goals of care. Certainly, there are a lot of lessons that we have collectively learned about how to manage nursing home residents with COVID-19. Constant assessment, low threshold to test, and here are some typical labs and studies that we ordered immediately upon learning someone was COVID-19 positive. Again, recent regulatory changes are now mandating frequencies of testing. And also with those mandates, we all must have our best strategies and partnerships with labs. Again, this is another tool our team developed around having a consistent way to assess residents. In my facility, residents have been since early March screened twice daily for fever, hypoxia, and cough. There are multiple challenges inherent in our setting, which we must anticipate and navigate. Infection control practices are necessary and require significant and ongoing vigilance and effort over time. And even if you do the right things, outbreaks can occur, particularly in communities that have significant positivity right now. And they require a plan for managing staff and residents and communicating with staff, residents, and families, as well as managing safely transitions of care. And despite having significant medical complexity at baseline, nursing home residents may experience a variety of clinical courses with COVID-19. I'd like to acknowledge some of my colleagues who I've been working with closely over this pandemic, including a medical student who helped go through the electronic medical records to summarize the clinical course of the residents in my facility. Here are some additional resources, and I thank you so much for your attention today.
All right, so we've got some guided questions here in response to that didactic there. So Dr. Levy, would you like to lead us through these?
Yeah, I mean, I'll just read the first one off and see if anybody has any thoughts. What is your, and also happy to answer any other questions you all may have regarding the video. But first question is, what is your facility's relationship with the medical director in helping manage changes in condition or developing COVID-19? I think that the relationship is probably pretty important when we're talking about acute illness. So wondering kind of what people's experiences are out there.
This is Michelle from Lakeside. We actually work pretty closely with our medical director and our doctor who's in-house, and their nurse practitioner. We actually had a PA who was our main point for the medical director and the group that's in our facility. And he was with us through the whole thing when we had our outbreak in the early spring.
Yeah, this is Bridget. That's across the board. All of our buildings and our medical directors are very, very involved, especially when it comes to anything that has to do with COVID-19. And to Michelle's point, that nurse practitioner was brand new. He'd never had an assignment before. So watching him come to the plate was quite awesome, though tiring, and we were a bit afraid. But we keep all of our providers very close at hand.
And he actually has been assigned to another facility who's had an outbreak, because he does know so much about COVID-19 now and what to look for on labs and all that.
Okay. Cool, thank you. Glad to hear that you all have had that support through these difficult times. Does anybody else out there have a different type of relationship with their medical director or provider staff?
This is Julia College Park. Our medical director is not on staff, but our medical director is available. But honestly, I think there's a support system there, and certainly will look up or help in any way that he can. But I don't think I can honestly say that he's leading the show as much as we're kind of finding our way with the assistance of our company and information and things that we need. And then I draw him in more so. He is at one of the local hospitals, a small hospital in town. So I think that also takes him away from being as much of a leader in the facility that I'd like to see. But I do feel he's there if we have an issue. So I don't want it to sound negative in that sense, but I'd like to give credit to our own internal team for finding the answers and maybe utilizing through our company's support systems and our regional nurse, et cetera, who's out of this world good, assists us through everything.
Thanks, Julie. Appreciate that sharing of that different perspective. And then I see Mark mentioned our medical director was very involved in setting up and quality assurance of our COVID cases, rounded and provided input on ways to improve our processes. And then Bertha mentioned our medical director is very involved. Dr. Pandori gave us a quick update, so we'll hold all questions. We'll make sure we collect those questions and provide them to him if they come up. And then Nicole second did Mark's comments. Medical director is very involved, provides suggestions, input, is engaged with new ideas. Great. Any thoughts on if you kind of, I guess, Julie, any excuse me, recommendations on how you were so successful in maybe not having that medical director leadership? You know, some kind of key pieces to that puzzle in case other groups don't have that type of leadership.
I'm so sorry. I was having a little difficulty. My speaker went down. So are you asking me how we did it without the medical director full time?
Yeah, some things that you thought that were kind of key to being successful in managing the COVID-19 cases.
Well, again, I think when it's all said and done, it's kind of up to all of us, you know, in a lot of ways to lead the day-to-day stuff with the guidance of, you know, wherever we can reach out for that guidance. And there's other physicians that are involved and that are here. So we certainly do talk to them individually as well about, you know, their patients or whatever. We've been very blessed to not have a lot of outbreak right now. We did back at the beginning in April and May where there was a lot more involvement. But I think more through QAPI and other ways that we communicate with our medical director. And then, like I say, I think we have a pretty close-knit group of nurses that try to work together, find out everything, research, and then, you know, we'll run it by any physician, certainly that is partnering in the facility. And I think there's a lot of interest through lots of different physicians and different ways of looking at things. But the bottom line is that if we do have a question on anything from a policy to writing it, I think we look more towards our regional nurse who stays on top of everything and assists us with moving forward.
Cool. Thanks for explaining. Definitely sounds like nursing staff is key to being successful. And then Troy, could you read Hope's, sorry, I gotta grab a drink.
No worries. Yeah, Hope shares medical director is involved in a reactive fashion. He has great insight with the acute setting updates, good liaison with house infectious disease provider. Thanks, Hope, for sharing that with us. Any other thoughts on this first question here, relationship with the medical director? All right, I think we can move on to question number 2 here. Does your facility have different staffing ratios for your COVID unit and observation units versus general nursing home unit?
This is Bridget. That entirely depends upon how many people are where. We do our staffing based on residents and need. We do try to Dedicate staff to the COVID unit if possible. That can be very, very difficult to manage as your staff gets sick as well. But as far as it's COVID hot and there's 8 people, we're going to give them 4 nurses. No. It's more like we manage it according to how many residents that we have to take care of, if that makes sense.
Yeah, I'll second what Bridget's saying. For example, when we test upon admission and they test positive, that's one person in my COVID unit. I'm not going to assign one nurse for that one patient. That's just, I can't do that. So although that's the recommendation, it just doesn't make sense when I'm hurting for staff anyway. So it really goes on a case-by-case basis for us.
Yeah, and to Nicole's point, what we've done on a one-off in one of my buildings was put the CNA with the resident, which the residents love that. They get that one-on-one. And then the nurse goes at the end of her med pass. That's the last, if possible. That would be the last resident that they care for, because we don't want any cross-contamination and going in and out of units. But that is entirely dependent upon availability of staff. And we have had to put one nurse in a unit with one patient in one building, but that didn't last more than a couple of days. So we get creative as well. For example, if you only have one resident that pops and you have a building across town that's really hot, you might move that one patient, deep clean your building, and put your hot people in one place. We've done that as well. It's about allocating your resources at the time.
Mm-hmm. Thanks, everyone. Yeah, seems like a lot of agreement in the chat box here. Michelle saying it also depends on how acute the patients on the isolation unit are. Susan says depends on how many residents are on the unit. Cardad says we dedicate staff for the COVID unit and usually 1 to 15 patients per nurse with 2 to 3 CNAs.
One question that I wanted to, sorry if I interrupted somebody, are you all kind of at max bed capacity right now, or are you guys keeping some beds open to help with the need for moving residents around, like the presenter had discussed, or just wonder, or does that also fluctuate depending on resources?
Fluctuates depending on resources. So for example, when there's just not enough staff to go around, and then as people get sick, and then as your census drops, and then we're at a point, especially in my buildings here, where we're trying to rebuild census, but we need staff to take care of the patients. So it actually becomes very, very difficult for the hospitals to even move the residents out. If that answered your question.
Yeah, that's what I was thinking, but just wanted to see if anybody had a different experience.
Yeah, so it's really hard. I mean, for the buildings that have been hit the hardest, resetting and getting back to where, for example, at Lakeside, I think we were in the 120s, 130s, and when we got hit in April, and then now we're managing an 80s to 90s census. So that hits us hard, but unless we have the staff and the ability to rebuild, we're sort of stuck.
This is Julie over at College again. I'm gonna kind of hit a nail on the head here too, because I think part of the issue, like when you talked about, I don't disagree with any of this by any means, but I think one of the problems that the nursing homes run into right now, as well as trying to find staff, is that we're, I think, up against a payment issue. When you're looking at the hospitals, and right now there's some pretty high paying jobs out there for nurses to kind of fly the coop to for a while, away from the nursing homes. And yet we're trying to manage this, the end of it, granted, but I think it's very difficult. None of us kind of know what to expect either, and being competitive to find that staff and maintain that staff, especially licensed staff in the nursing homes, when we're kind of forced to be a bit competitive to each other depending upon the levels of care out there right now. Mm-hmm.
Yeah, great point, Julie. I think somebody had discussed that in a previous echo as far as competing for, really high hourly rates and people working in the ICU COVID unit versus what they may get paid in working in a nursing home COVID unit. Bridget, I see you took yourself off mute.
Yeah, I just want to echo that. It's very, very difficult. I mean, it's how do you compete when you can't manage your revenue with the loss? So I think we have been looking at, in this particular region, not necessarily New Mexico, but here, retention, trying to build more loving atmosphere, I guess. But also the work is very, very difficult. What we provide for the community is extremely important, but it's really hard work. And I think some people are figuring that out. And if you can cross a COVID line and make double what I do, then it's probably a good gig if you can get it.
I'll also add to this discussion. I think a hard part of recruiting is actually the stigma that gets put from the media onto nursing facilities, especially that happened in the early pandemic. There were just some really ugly articles that came out with really stigmatizing headlines that when you read those headlines, it makes it hard to recruit good quality staff. And so for myself, I was really upset when I saw some of the media headlines that were coming out around nursing homes and COVID. And I do think it's going to be something that stays damaging. And I do hope the media changes some language around it.
Thanks, Theresa. Great perspective there. I appreciate it. I think we have had a lot of comments in the chat. Troy, do you want to run us through some of those?
Yeah, quite a few comments in the chat. Really appreciate everybody sending these in. So Mark shares, yes, related to the amount of residents infected and PPE don and doff. Very challenging issue regarding staffing. It's based on quantity of residents with COVID. It's a day-to-day decision based on staff and staffing. Daniel shares, yes, we have different ratios for our COVID unit. Hope says, yes, designated COVID staff. The acuity of the symptom management is the key to effective staffing with COVID. K-Don says, if our staff is working long-term care and we have a COVID patient on the acute, that staff working in long-term care will stay in long-term care and vice versa. Kadon also shares, we have a hall in our acute setting that is set for COVID patients. It's only 7 beds. At one point, we did have them all full with acute patients. And then Nicole says, we were able to minimize our COVID unit because our census is thankfully growing, but I do have 2 rooms, 4 beds reserved in case someone converts to a positive status. I have 12 beds for our new admission quarantine unit, and those are all full, but asymptomatic.
Cool. Thanks for sharing. Sounds like everybody. Sounds like Nicole, you're and also Kay, Don mentioned. Sounds like you have a quarantine. That quarantine unit could potentially serve dual purposes if you need to with those new admissions, depending on who's around. And sounds like you're still saving a couple beds just in case something pops up, so you can kind of quickly isolate it. So cool, very cool. Thanks for sharing.
Yeah, I really appreciate everybody jumping in on this question here. We'll move on to question 3 here. If an auditor asks a nursing home team member to differentiate between mild, moderate, and severe cases of COVID-19, would the staff person be able to articulate the differences and how to modify treatment if needed, including when transfer to a higher level of care might be considered?
That's a good question to ask our team.
Yeah, I think super critical question as far as clinical question, as far as understanding, what people look like and what kind of the warning signs are of illness. A couple of weeks ago, I did mention the pulse oximetry, and looking at that and people's oxygen status might be a sign that they may not be doing better, but at the same time need to consider who we're using that clinical test on and making sure we're interpreting it with other types of clinical signs. What types of clinical signs would you guys see to to put them in the moderate severe case? What would you see from your residents? What would you expect to see if they were more moderate to severe rather than mild?
This is Michelle from Lakeside. I would have to say the severe, of course, would be the very low oxygen saturation that we're not able to control without needing to have a higher flow of oxygen. Destatting, altered mental status, something just became so acute that they need, ICU or ventilation possibly because we just can't get them to recover from whatever episode they're experiencing.
Thanks, Michelle. Yeah, oxygenation status, work of breathing, altered mental status or delirium or acute confusions, really important, showing that the illness may be getting worse. Thank you for sharing. Any other signs out there?
I was going to add for if an auditor asks the nursing team now, for those who were there during our outbreak, I would say yes, they probably could. However, prior to having the outbreak, they would probably think everybody who had any kind of change would need to go to the hospital.
The only thing that I really remember other than what Michelle said was that I haven't been a clinician for as long as I have and been around the block a few times. There's certain signs of death that I would look for normally as an ICU nurse or someone trained in that sort of thing are not the same when COVID residents are passing. The body changes are not the same. The leg modeling it's not there. There is truth that their nail beds turn blue, but you don't realize that until you get to your third or fourth person. And then, so then you start to see the different signs and then you can start putting it together a little bit differently. But that's at the bedside.
So I see Kate Dawn mentioned that the nurses would be familiar, but the CNAs would not be as familiar. And then Daniel mentioned they have a COVID unit with dedicated staff that are trained to work closely and daily with the infectious disease, but the unit is always full, which helps with ratios and resources as we have it open for admissions for hospital cases. The staff is trained on the capabilities of the unit relating to O2 flow capabilities, SATs, labs, etc. Great point. Does anybody look at fever or blood pressure in helping differentiate between, or heart rate in differentiating between kind of mild, moderate, or severe? And what kind of changes do you see in those when you think people are transitioning from stages?
I like to mention something regarding the question, number 3. So we got hit very early on here in Horizon, and generally we would see patients that are either kind of asymptomatic or patients that were maybe just having malaise or weakness. But really the tipping scale for us was when the patients would have increased work of breathing. And then, very early on, we would see that they were having desaturation. So from my perspective, we would see asymptomatic patients, somebody who's positive, that we have testing, we'll see a patient who's positive, they present with those symptoms. Then we see patients that may be a little bit, listless, but nothing significant. And fevers really were more of a one-off, at least for us here. You would see potentially a fever for a short period of time, but it was not something that would last. But the issue that really was deciding was the work of breathing and the desaturation. So when a patient would start to have a change from baseline of maybe 1 or 2%, then that was something that we, as we're doing more increased vital monitoring, that's really the telltale sign for us here. So fevers played a little bit of a role as far as I can tell, but they weren't really the marker that you would think, because it seems like the fever itself wouldn't last. That's just some observations from us here.
Yeah, really.
Thanks, Mark.
Thank you. Kind of along those same lines of kind of those smaller changes, Hope shares, the acuity can change in hours from mild to severe. COVID staffers need to be experts in recognizing slight changes quickly.
Yeah, I think that's a great point, Hope. I think lots of our residents, especially those with communication difficulties, especially dementia, we have to be super keen in knowing who they are and understanding those small changes, because as they add up and the longer it takes us to recognize them, there's potential for those outcomes to be worse. And my impression is that I think a lot of many of you all are doing great jobs just based on the mortality rate of a lot of our nursing home residents compared to other people across the country and the world, but still can never be understated. Super. Thank you for pointing that out, Hope.
Excellent. Thank you, everyone. Really enjoying this discussion here today. Last question here, and then we'll hurry up and wrap up today. Are there written communication materials and resources to inform everyone about how to manage mild COVID cases in the nursing home? So it's sort of written materials or resources do you have available for your facilities? Go ahead, Nicole.
Yeah, I mean, we have a lot of written material. The problem is whether or not the staff take the time to actually read and digest all of it. So as Bridget mentioned in a previous session, that you really just need to talk one-on-one with the staff and make sure that they understand, because especially there was so much information coming out all at once, and then it was changing day after day after day, people just stopped reading it. So for us, it's just constant communication with the staff and then supply the information, but to me, that's not the best form of communication when things change so quickly.
Yeah, I think number 4 was potentially a tool you could use as you ask number 3 as you guys go around the next week and see if your staff is able to modify. See if you can use if a written communication or a paper communication may be helpful to supplement everything that you're sharing. But just something to consider as we go forward. Cool. And then I think there were some more questions here. I think we can just probably, I would just say, unless we'll kind of leave these up here for about 30 seconds. If anybody has some thoughts, we'll leave it open. Otherwise, we can make sure we're still respectful of everyone's time and we can kind of move on to the wrap up.
Doesn't this go back to the ongoing conversation of how many spreadsheets do we open a day?
Yeah, that's why I put them on the second page. Was I don't want to be, I know we've talked about
this. Yeah.